Good morning, everyone. Good afternoon. My name is Sarah Walbolt. I am co-owner and co-founder of Sanguine Health Holdings, and I feel very honored to be with you as a global audience today to host the sixth and final day of our Bloodless Medicine and Surgery event. Bloodless Medicine and Surgery Week is wrapping up, but remember that we have an entire month to bring awareness to bloodless medicine and surgery, and our work isn't even done then. Hopefully, we have learned things that we will take back into our medical practices and promote this superior form of healthcare. Bloodless Medicine and Surgery Month and Week is organized by the Bloodless Medicine and Surgery group at the University of Calabar in collaboration with the Bloodless Medicine and Surgery Society and the Advancement of Patient Blood Management SABM organization. So thank you for all those great organizations for organizing this event for us here today. I am privileged to be co-hosting today with a fellow nurse, Abigail Ibarra. She is the Chief nursing officer at the University of Calabar Teaching Hospital in Calabar, Nigeria. And she's a co-moderator with me today and co-founder of the Bloodless Medicine and Surgery Society. Abigail, welcome.
Thank you very much, Sarah, for welcoming me here. I'm glad to be with you. Welcome, everybody. Good morning over there. Good afternoon and good night, our fellow panelists and everybody. Happy to be with you. Just to remind us a little again about this 2023 Bloodless Medicine and Surgery Week, which is concluding today being the 6th day. The theme being Bloodless Medicine, the nuts and bolts. We are so happy because the week is filled with brainstorming. We really appreciate the audience from various countries that are participating all over the world except Antarctica. So the program today will feature a talk by a seasoned young pharmacist and a quiz to test our knowledge of the basic concepts of bloodless medicine. We still want to remind us of some housekeeping. All questions should be placed in the Q&A section. I will also employ everybody to minimize chats during the talk so as not to distract our attendees and the speakers. And then this program is also being streamed live in the Bloodless Medicine and Surgery YouTube channel. In case any of us has difficulty with the Zoom, you could please click onto your YouTube link and type Bloodless Medicine and Surgery site in YouTube search, and you'll see us live. And we also want to remind us that because some persons might have a distraction from the background, please, can you please minimize that so that we enjoy the session very well. Sarah, please, I'm handing over to you. Thank you.
And now it's a great privilege to introduce pharmacist Obed Aidu. Obed Aidu is a board certified pharmacist from Ghana and a member of the Pharmaceutical Society of Ghana. He has worked as a pharmacist in charge of Sonatec Medical and Diagnostic Center, Accura, Ghana. He then worked as a clinical administrator in Lena House Clinic, Tema, Ghana, where he was involved in instituting PBM and bloodless medicine protocols. He was also directly involved in providing patient care, especially to those who wanted to avoid the use of allogenic blood transfusions. In Ghana, he has been involved in research in bloodless medicine and published in the Ghana Pharmaceutical Journal. He is currently studying for his master's in public health in Torrens University, Australia, with interests in medical research, integration of public health into clinical care, development of strategies and protocols for training healthcare professionals in bloodless medicine and surgery. The title of his presentation today is Bloodless Medicine in Renal Dialysis. Welcome.
Thank you for having me. I need to set up good. All right, so once again, my name is Obed Aidu, and I'm presenting on bloodless renal dialysis, the scientific option. Before we talk about renal dialysis, we would like to talk about chronic kidney disease, because in most cases, chronic kidney diseases precedes renal dialysis. So what is chronic kidney disease? It's a clinical syndrome secondary to definitive changes in function and structure of the kidney, and it is characterized by its slow, progressive irreversibility of the change. And there are some predictive tests that could be used in CKD, the urine albumin creatinine ratio test, in which a value of more than 30 milligram per gram is indicative of microalbuminuria, which could be used to predict chronic kidney disease. We also have the urine test, in which proteins identified could be used to predict chronic kidney disease. However, there was a more conclusive test, which is the EGFR, estimated glomerular filtration rates, and we have various stages, as you can see on your screen. And at stage 5, where we have the end-stage kidney failure or renal disease, that is where dialysis is being deployed. Now, in management of CKD, we have the medical management, in which the concomitant diseases like hypertension is managed with our ARBs and ACEs, our diabetes managed with our antidiabetics. We also have the dialysis stage whilst we are awaiting transplant. But in our part of the world, how many people can afford kidney transplants? And even access to it is a problem. So usually dialysis is a lifelong management, and ultimately the transplant. But in our discussion, we are going to zoom in more on dialysis whilst awaiting transplant. So dialysis is a kidney replacement therapy. Usually it is used temporarily in acute kidney injury, where we are waiting for the kidney function to be restored. And we also use it in end-stage renal disease until the donor comes. But once again, in the context where we are looking at this, access to kidney transplants and even cost is a problem. So it's a lifelong management. We have various types: hemodialysis, peritoneal dialysis, hemodiafiltration, online hemodiafiltration, continuous renal replacement therapy. But in our part of the world, what is common is the hemodialysis and the peritoneal dialysis, and that is what this discussion or presentation would focus more on. So this is a diagram trying to depict the principle in hemodialysis. So we have blood pumped from the patient being monitored, the arterial pressure being monitored. It gets to a point where heparin is injected into the blood to prevent clotting. Then it gets into the dialyzer. In the dialyzer, we have the dialysate, and this is a solution containing water and solutes like magnesium, potassium, and dextrose. So this is hyperosmolar, and there's a continuous flow of the dialysate to maintain the osmotic gradients so as to allow the exchange of solutes from the blood to the dialysate. These solutes are uremic compounds or putative inhibitors. Under normal circumstances, if the kidney is not compromised, they are supposed to be excreted. But once the kidney is compromised, they stay in the system and they become biologically active and cause a lot of troubles, which we would find out later in the discussion. Once the uremic compounds are gotten rid of, the blood filtered and pumped back into the patient. The other type, peritoneal dialysis, it works on infusion and drainage. So we have, once again, the diacylate hyperosmolar being infused in the patient, and it uses the peritoneal lining as the exchange surface, and the uremic compounds are being transferred into the diacylate, and then it outflows out of the body. But before a patient would be put on dialysis, preparation is very key, it's very important. Once again, we said that dialysis is started when the EGFR is below 15. Some school of thought even say plus symptoms. So before the patient gets there, there is the need to prepare the patient psychologically, financially. Again, it's a lifelong treatment. So there's the need for all this preparation. Even medically, there's a need for preparation. In our part of the world, we don't have isolation dialysis. So there's the need for screening the patient for hepatitis and vaccinating the patient. All these take time. So we need to prepare. Even the hemodialysis, research shows that the arteriovenous fistula and the AV graft are better than the normal catheter we use because of infection risks with the normal catheter. So you would need a surgeon to fix the arteriovenous fistula, which is more preferred over AV grafts because of incident of thrombosis with AV grafts. Then the peritoneal dialysis to reuse the Tenkov catheter, which is more comfortable and has low infection risks. Now, the complications of CKD are anemia and thrombocytopenia. These are the areas that are of importance to us today. So we'll be looking at the anemia and thrombocytopenia. How does CKD cause anemia? It is all due to the uremic compounds. These are normally gotten rid of from the body if the kidney is not compromised. And there is one of the uremic compound called hepcidin. High levels of hepcidin affects erythropoiesis. It affects the iron stores, and then we have anemia. And these uremic compounds also affect the functions of platelets. So then we end up having thrombocytopenia in the patients. Now, the effect of dialysis on erythropoiesis is a positive and a negative one as well. The positive aspect is that the uremic compounds are able to be eliminated. That is what is expected to be eliminated from the patient's blood. Once these uremic compounds are being eliminated, then erythropoietin can work well to initiate erythropoiesis. Then the iron stores are not being affected. Once erythropoiesis is maximized, there's also prevention of phagocytosis of the red blood cells, and the inflammation mediators are also gotten rid of by the dialysis. In as much as dialysis promote erythropoiesis, it can also impact on erythropoiesis. Iron deficiency will develop in many dialysis patients as a result of treatment-related blood loss and a high demand for erythropoiesis. So it is very key that patients on dialysis are being monitored and managed for iron deficiency. We should note that sometimes the iron stores would be perfect, very good, but then the circulating ions might not be that good. That is why our TSAT and ferritin tests are important. The TSAT would inform you of the adequate circulating ion, and these circulating ions ensures that erythropoietin therapy is optimized. So we need to make sure that our dialysis is adequate. If our dialysis is not adequate, there's going to be buildup of hepcidin and other uremic compounds, which would affect erythropoietin therapy, will lead to hypo-responsiveness of our EPO therapy. But what if we check the patient and we find out that the stores, the ion, circulating ions is low? That is when we fall on our Ganzoni formula, where we use the weight, the body weights of the patient in relation to our target HB and the present HB to calculate the amount of ion to give the patient IV. Usually when this is given to the patient IV for over 5 hours, it prior to administration of our erythropoietin, it optimizes the erythropoietin therapy. So you need to take note of our ion stores as well as the circulating ions. Then thrombocytopenia, once the dialyzer gets rid of our uremic compound, again, it's the uremic compounds impact on platelet formation. So in effect, it affects for thrombocytopenia. So once they are gotten rid of, then thrombocytopenia would be taken care of. But this same dialyzer can also lead to thrombocytopenia. As in the past, we used to use a dialyzer known as cyprophane membrane, the dialyzer with cyprophane membrane. And these were shown to cause complement activation, leading to thrombocytopenia. But new technologies have evolved, and now we have polysulfone membranes, which are associated with little complement activity. So then platelet thrombocytopenia is reduced with them. And even in them, in using the polysulfone membrane, you realize that there's about 5% decrease in platelets count. So whichever way we look at it, dialysis is important for patients with renal disease, especially when it comes with managing their anemia and thrombocytopenia. And at the same time, they cause what? Anemia and thrombocytopenia. So that is why bloodless medicine is a key when it comes to manage our patients on dialysis. They need to be monitored and managed well. And in dialysis, there's a low-grade fever, which also impacts on erythropoiesis. So all these point to the fact that there's the need for bloodless medicine in our patients on dialysis. Now, what some clinicians do is that they infuse allogenic blood transfusion, or they prefer allogenic blood transfusion. But in a research, landmark research here in Western Australia, Leahy et al. 2017, it clearly shows that allogenic blood transfusion is associated with increased mortality, increased morbidity, increased hospital stay. But implementation of patient blood management is associated with improved patient outcome, and it's also cost effective. The problems with allogenic blood transfusion are a lot. We have dilutional thrombocytopenia, infection complication. already the patient has low-grade infection. So if you infuse blood transfusion, which are, if you infuse allogenic blood, which are infective, then it is going to worsen the patient's condition. Then we have the non-infectious complication, the Trali-Taco, hyperkalemia, iron overload. Now, our bloodless medicine strategy, one of the key things we have to put in place is to prevent iatrogenic blood loss. So we encourage microsampling. I think yesterday, the doctor from Johns Hopkins spoke extensively about this, and you realize that even experienced doctors back in Ghana make these mistakes, and it affects the patient. So micro sampling should be encouraged in management of patients on dialysis. Even with all our patients who are anemic, micro sampling very important. And anemia management of CKD should include our erythropoietin ion. We shouldn't forget our circulating ions. Make sure there are enough circulating ion, vitamin B, folic acid. And nutrition is very important. Nutrition is very important. So we should include the dietitian in the management of patients on dialysis. With the platelets, we have our thrombopoietin receptor agonist. We have our recombinant human thrombopoietin. Treating of our infection, you shouldn't forget our broad spectrum antibiotic. We are also saying that research shows that the AVF and the AVJ are better because they have low infection rates compared to the normal catheters we use. Then our dialyzer membrane, you would want to use the polysulfones instead of the cyclophones. So our recommendations are that we should avoid the wait and see approach when we care for our CKD patients. We should improve medicine availability should be improved. Now, medicine is shifting towards a multidisciplinary approach. So this is not a one-man show. All other healthcare professionals should be brought on board, especially even the nutritionist has a role to play. So we need to do that and avoid use of catheters. We need to train more specialists in renal treatment, especially pharmacists, nurses, physicians, and we should develop local solutions for local problems. These are my references. Thank you very much.
Thank you very much, Pharmacist Thaddeus. We really enjoy your presentation, and I'm sure the audience would. All over the world, we find out that especially in this 20th century, renal dialysis has really been the only RRT for remedy patients. And especially in our area here, we find out a lot of persons fall down with kidney failure. You've analyzed most of the problem, though the causes, we may have to browse about that, but if we have to talk about it, there are so many things that could bring down kidney failure. And interestingly, that's my specialty. So I'm so glad that you came up to give this presentation. We hope that next time is going to be more expanded this. And besides that, we have some few questions here in Q&A. One is by Double Lee. He says, besides talking or advocacy, what other prerequisites are there for starting a similar program in a particular medical center? I don't know if that question is really for you, Pharmacist Thaddeus. And the next question still from him. You may kindly send answers to the above question to W, okay? So I've been away from the webinar to care for some important tasks. Okay, so this question by W, please could you answer it, or we send an answer to him like he has stated. His address is here, w120@gmail.com. That's the only question we have for now. Please, the audience, if you have any other question and you don't intend to type, you could raise your hand and we'll get back to you. Any of the panelists could answer the question that will be raised. Thank you.
Yeah, Abigail, I'm thinking that question about besides talking through advocacy, what other prerequisites are there for starting a similar program? The panelists here, including Sarah, there are a number of them that are running bloodless programs. So I think I see their hands up, or otherwise I'll put it up for them so they could help answer the question.
Yeah.
And so is his question, he's asking, besides talking advocacy, what other prerequisites are there for starting a similar program in a particular medical center? So is he talking for dialysis, or do you think he's speaking about bloodless medicine and surgery?
I think since this is a bloodless forum, he's
Okay.
probably having in mind bloodless.
Okay. Does any one of our panelists want to weigh in and start with their thoughts of how you get started? Anyone?
I think we haven't heard Sandy's voice. Okay, her hand is up. I wanted to put it up for her.
I don't think we're hearing her. Are you muted? Are you muted, Sandy?
There we go. I think you can hear me now.
Yes. Yes. Thank you.
Good morning, everybody. It has been such a pleasure this week getting to be a part of this. My name is Sandy Mann, and I actually worked with Sarah, had the pleasure of working with Sarah at our blood management program in Ohio, in Toledo, Ohio, for many years. So that was a program that we had laboriously started years ago with Dr. True. As a lot of you may know him or remember him, and Jackie Nussbaum. And really, you know, blood PBMs have advanced so much to what they are now from the times when we were all kind of putting them together from scratch, literally, and many of them starting from just a bloodless program, volunteer program at that, many times in the hospitals. And they were just really a labor of love at the time. But now, with the advancements that we've made and just the recognition that PBMs have got, and I know I'm kind of generalizing. I know we've spoken a lot about what it takes to start a PBM program now in a lot of these hospitals, but really in the end, what it really is you need buy-in. You need to find the supporters within the hospital system that are willing to support really our cause and believe in the benefits that blood management can bring to the whole hospital system as a whole. And really, for them, you know, they're also looking at profit and saving money and patient safety and patient care. But they many times have to be convinced that, oh, it is beneficial. Oh, this does not just treat or help a certain little small population in our health system. However, everybody can benefit. And listening to yesterday's program with oh my goodness, I just forgot his name, John Hopkins University.
Stephen Frank. Yeah, Dr. Frank.
Thank you, Stephen, Dr. Franks. It just goes to show that the support system and the structure now, there's so many levels within the department that can help take care of everybody, but they have the whole thing down to a science. We even just doing micro draws for everyone, pediatric draws, and so really what you need, of course, is, and Sarah is so much better at talking about some of the structure, but you need to have your medical director, and it helps to have a nurse practitioner now, especially if you're in a bigger hospital system. And definitely your nurse coordinators, someone that can go see the hospital, the patients that are hospitalized inpatients, but also, you know, now we have anemia programs, and those need to be seen. And so we have prevention, building up patients before surgeries and pregnancies, and as well as while they're in patients in the hospitals, protecting them and being their advocates. So I know I'm jumping around, it's a little early here, but really it's such a big effort on so many parts. And when Dr. Franks and Isha were talking about teamwork, absolutely, it is teamwork. There's so many there's a lot of moving parts in the end to make it all happen in the hospital system. I know I'm missing a big part of this, but
you're great. Any other panelists have any advice that we can send to Lee? I don't know what position they serve in the hospital, but I guess I will draft a response to them, but start where you're at. So I don't know where your specialty lies, but start where you're at. We would like to get C-suite support. Sometimes we get it right away. Often we do not. The next best thing is to find a physician who will sort of back you and help you. If you can get a physician to sponsor you, then, I think management takes it more seriously. They are interested in quality improvement. And so, start where you're at and where your specialty lies and how you can affect that small area. And it may be somewhat of a volunteer of time. And I think that a lot of these programs have started with volunteering and creating the position within their organization that way. And find a mentor. So I think, people here, there's a lot of clinical specialists in implementation, and all of us are great at sharing. And so find a mentor that can help you know, we need to know where you're at, how big is your facility? We got to find what doors to knock on. And if you get a closed door, then you go to another door. So find a mentor. SABM has a great mentorship program, but I know that if you even reached out to any leader in this that you can think of, that someone that you've heard talk at a presentation, most everyone would be willing to point you in a direction or to mentor you. Any other advice from the panel? I think it's a very important question, is where to start. And it's a monumental task. And so take it from where you can would be my best advice. And get involved with SABM and Bloodless Medicine Surgery Society, because they will assist. So,
Sarah,
yes.
Sarah, hey, good talking about the ability of SABM to have a mentor program. And by the way, this is Jessica Varisco. It's very early here this morning, so good morning. So I've started two ways. One, I've run 3 different programs at 3 different hospitals, and they're still in place today. The first one was the OR director had started a bloodless program herself in one hospital because she had a lot of requests for this from people who were not Jehovah's Witnesses or had a reason to do it because of religion. And she reached out to me because she had everything in place for the program as the OR director. She had done some due diligence. And so she reached out to me to, do the business part of the program. The other program started because I had a physician, a surgeon champion who had met me and had worked with me for many years. And he just said, he told administration that he needed to have a bloodless program where he was and would like to engage me in the program. So that's the C-suite or administration. If you have administration backing and you do a small or brief business plan and present it to administration, that would be a great thing to do. And then from there, it just steamrolls because you have admin backing. And if you can do that, then, you have it easy to gather the groups that you need to start a full program.
Thank you so much, Jessica. Any other thoughts?
I just wanted to also support what Jessica just said, and you, Sarah, about SABM and LBMSS and different various ones. The support you get from them, guidance, little things you may not always think about that could be helpful to educating administration, doctors, the nurses, all the teams involved in taking care of a patient. Really helps plug in the little holes where you might miss it yourself in a smaller department, for instance, starting out. Let them guide you and set the standards, and also just turning your hospital onto SABM, onto BMS, and just letting them know this is available to us. Let them see what other successful PBMs are doing around the country or the world or your country. Just to, instead of taking it all on yourself, because it is a big enchilada.
Yes.
Like Sarah said, starting small, starting where you are and seeing what the potential is. And also just showing, again, letting them know, like in smaller hospitals, for instance, how this is gonna help the patient, the departments, the doctors, the staff, that we are supporting all of them, not just an advocate for the patient, but as well for the surgeons, the anesthesiologists. Everybody is supported in it.
And we do have an answer that was typed in from an anonymous attendee. It says that they built a program physically with a medical director and a coordinator, but used the EMR to screen for patients upon admission and to provide detailed order sets like anemia management for patients who refuse blood, which can give direction to providers. Great answer as well. Thank you for that comment. I did have a question for our presenter today on the hemodialysis. They use heparin as a form of, blood thinner so that it does not clot the machinery. Does that heparin affect them on their non-dialysis days? So does the dialysis patient need to be cognizant that their blood is thinner even on their non-dialysis days? How long does that heparin stay in their system from their treatment? Not sure if we're able to get his response.
Obed, are you there? The question is for you. Please, can you unmute and answer, please?
He may not be able to hear us.
What was the question again?
How much does the heparin that's used in the hemodialysis? They use heparin during the procedure of hemodialysis. So do Bloodless or do patients need to be aware? Are they continuously having this blood thinner in their systems on their non-dialysis days? Or is the heparin's gone basically after the dialysis is done? Is it like filtered out?
Well, I hope Obed, okay, he's here. Let him take that question.
Yeah. So the heparin is injected during the procedure to prevent the clotting. And once it is injected, it still stays in the patient's system. So that is why the heparin could even induce thrombocytopenia afterwards. So there need to be a whole lot of preparation and counsel, with use of anticoagulant, things they are supposed to do and all that. So it still continues to stay in the system. So there was a need to manage thrombocytopenia.
Okay, thank you.
But correct me if I'm wrong, but it's relatively, I mean, there are longer acting anticoagulants. Heparin is relatively short acting and should be cleared out of the system within a few days.
Okay.
Can I contribute?
Yes.
Yes, please. You're
Okay.
a renal nurse too.
Okay, yeah. Actually, heparin is not given when the patient is not due for dialysis. And we are treating our patients individualistic, holistic care. So there are some patients that are heparin free. It's not all the patients that heparin can be used. As we know, heparin can be dialyzed. It's dialysable. It's one of the medication that is dialysable. And so if before the preparation for dialysis is made, about 0.5 international units of heparin, which is very significant, is diluted with 500 mils of normal saline, that's 0.9%, to prime the line. And that's the blood line. The essence of that is to enable the ethyl, that's the preservative that is used for the blood line, not to enable the patient not to react to it, because there are some reaction while the patient is under dialysis, could be disequilibrium or first use syndrome. So why we use that significant heparin is to enable that to be dialyzed. And we, as the blood is connected, the arterial line is connected to the patient's arterial line first, we have a bag that is hung up the waist back, that the whole heparin is infused right in there. So while the session starts, we give a bolus of 2,000 international unit, that's 2 mils. And after about 1 hour, we give another one, depending on the coagulation ratio of the patient. And then if a patient has AV fistula, you're going home in the next 4 hours. So 3 hours or an hour to when the session is to be terminated, we stop the blood pump of the heparin. So there's nothing in the blood system again. But because you already have like 4,000 international unit of it, which is not so much, we arrest the bleeding when the catheter is removed and the patient is observed, because there are a lot of complications if excess of heparin is left inside the system. So it's usually insignificant. Before, let's say, 8 hours of that day of dialysis, there's no heparin that is there any longer. As two, if a patient's coagulation party is less, we use very minimal, or we dialyze you free using normal saline to monitor until that is done.
And then I think one of the recommendations was to avoid the use of catheters. I was wondering what the alternative was to using catheters in hemodialysis or in dialysis.
Okay. You're talking of the use of catheters?
Mhm.
We
Yeah, I think-
have what is called a lifeline for a patient on dialysis. And to avoid anemia, the patient cannot be, because you are supposed to be on dialysis 3 times in a week. So we avoid pricking. Phlebotomy every other day will even help to reduce the patient's and red blood cell. So we institute a lifeline for those who cannot afford the AV fistula or AV graft. We get another temporal catheter, which is either subclavian or internal jugular catheter. But emergency purpose, we give you femoral catheter, and that could just last for like 3 days, and we pull that out. So the use of the catheter is to enable the patient to have, free dialysis anytime you come, to avoid the phlebotomy.
I understand. So the AV fistula is the alternative, is where you want to move towards that. Okay, makes sense. Thank you so much. Very good.
Thank you so much for this presentation. All the years we'll be doing bloodless medicine and surgery, we'll be talking about either O&G cases, medical cases, surgical cases. So today, renal dialysis is still part of medical and surgical case, because we talked about transplant, which most of them can live their lifetime with. So we will be rounding up this program today by going into the quiz section, and I'm handing over to you, Sarah. Please, can you share that? Thank you very much.
Thank you. I think James is going to play for us a couple videos, and then we will end our day with a fantastic quiz. So James, please start the videos.
Providing bloodless care to patients is simply providing medical care without giving patients blood donated by another person. The way we do this is to conserve blood by reducing or eliminating bleeding, by stimulating the body to make its own blood cells at an accelerated rate, and also by recycling blood that patients lose during surgery and giving them back their own blood. Well, there are several reasons why patients may choose a bloodless approach to their surgery. Historically, patients have elected to avoid transfusion because of religious reasons, but also some patients just simply wish to avoid the risk or the side effects of transfusion. For example, we know that patients treated with the bloodless methods have a shorter length of stay, decreased incidence of hospital-acquired infections, and also less chance of an allergic reaction or even receiving the wrong unit of blood, which still occurs. The first thing we do is we diagnose or treat anemia prior to surgery, so patients come to the operating room with enough red blood cells so they can tolerate any blood loss. During surgery, we can avoid hypothermia or hypertension, both of which can increase bleeding. And then we can collect and recycle the blood they lose using the cell saver and give them back their own blood during surgery. We can also use what we call ANH, acute normal volemic hemodilution, which is where we bank the patient's own blood at the beginning of the case and give it back to them at the end of the case. There's one more technique. There's new versions of electrocautery that have come out recently that can dramatically decrease bleeding during orthopedic cases and during spine surgery, for example. Virtually 99% of all the procedures we do can be performed without transfusion. For example, we've done some really big surgeries like a Whipple for pancreatic cancer. We've done many of those without transfusions. We've done open heart surgeries, even revision open heart surgeries for valve replacements and bypass surgery without blood. And recently we even did a 6-kilogram baby, that's about a 14-pound baby, who had open heart surgery for tetralogy of Fallot, requiring cardiopulmonary bypass without a transfusion. We believe that we offer more different types of specialty care than any other hospital in the country that has a bloodless program. Plus, our program blends seamlessly into the care plan that's offered by all varieties of specialties within the hospital. Surgery itself is becoming less and less invasive. For example, the laparoscopic and robotic approach to different surgeries have dramatically decreased the amount of blood that patients lose and the amount of transfusions they require. Also, we're giving new intravenous medications like iron, or we're even giving erythropoietin, which is one of the medications that the professional cyclists use to blood dope. Only now we're giving it legally to our patients to build their blood counts prior to surgery so they don't require a transfusion.
Every year in the U.S., patients receive 21 million blood transfusions. What if there was a better solution with significantly improved outcomes?
So nearly every surgical procedure involves some degree of blood loss. and traditionally give patients blood from the blood bank. However, another option exists, which is called bloodless medicine and surgery, where we use alternatives to transfusion.
Techniques performed before, during, and after surgery result in minimized blood loss, faster recovery, fewer infections, and quicker discharge. Bloodless medicine eliminates the need for blood transfusion, thus avoiding the dangers of allergic reaction, contamination, and the possibility of receiving the wrong blood type. Before surgery, medication and nutritional supplements increase hemoglobin levels, which help your body handle blood loss during surgery. A process called hemodilution temporarily replaces a portion of the patient's blood with fluids, lessening the impact of blood loss during surgery. Tools and techniques used during surgery include anesthesia processes to safely lower blood pressure. Harmonic scalpels clot the blood while cutting the tissue. Cell salvage machines collect lost blood, wash it, and return it to the patient. Hemoglobin monitors reduce the need to collect blood samples to be sent to the lab. After surgery, medications and techniques can minimize bleeding and improve oxygen in the blood. Often after surgery, blood must be drawn to run follow-up testing in the lab. Microsampling requires 1/10 the amount of blood traditionally drawn, reducing the amount of blood patients lose by almost 90%. At Johns Hopkins, our team of highly trained experts have been providing patients alternatives and peace of mind for years.
Those are some great videos. I especially appreciate John Hopkins for creating videos for the public awareness. And I don't know if all of you have been able to sort of see that there is a shift, that we are kind of wanting to educate the public more and more about their options and in bloodless medicine and surgery. And I'm wondering if any of you here today have created similar kind of like public awareness education in your facilities. Has anyone had any experience with that, or what they're doing to kind of educate the public?
While Sarah is discussing that, James, do you have some more videos?
No, that was it. There were 2 videos.
Yeah, but in your store, I think you have more videos, right?
We have someone, Ananthi.
Okay, Ananthi has.
Yeah.
Okay.
Have you created some like public awareness campaigns?
Yeah, so I don't have a video with me now, but yeah, from the Malaysian Society of Patient Blood Management, there is also some videos that we have created. It's on our YouTube channel. So perhaps later I can send a text in the chat for everyone, then they can have a look at the videos. So there was a 6 series, 6 videos actually, on different topics. Like one was what is patient blood management, and then dangers of transfusion. The other one is perioperative PBM. Number 4 was something about iron deficiency and IV iron therapy. And number 5 was something about pediatrics and ONG, I think. Yeah, so those were kind of made so that the public can learn something. And we did have some subtitles as well included inside, Malay subtitles because yeah, it's Malaysia. So English language, but yeah, Malay subtitles. So that's what we have.
Very good. Very good. Any other type of outreach programs, or, I'm kind of trying to stimulate us to be able to carry on our bloodless work beyond this week, and so if you can share with others how you promote it within either your organization or public, it will give a lot of us, maybe some ideas. I can tell that there's a big shift to kind of giving public awareness to blood health. And I think that is going to be a kind of a game changer for, hospital organizations and healthcare organizations when, the public is more educated and asking for this type of therapy and treatment.
Sarah, I just wanted to say, we're hearing the term blood health a lot more, and that does actually help, I think, the public and the hospital systems to understand blood management can sometimes be a little confusing to them. They are what is that? Oh yeah, we have a lab. Yeah, we try to, reduce our blood draws or whatever. They don't fully understand what blood management is. Whereas blood health is so much more encompassing. It's everything. It's the patient, overall doing better because we've watched their blood, because we've protected them from certain things. And, another thing I was thinking too is a lot of hospital systems, they may be buying into a certain part, an aspect of blood management, which is of course always good. But for instance, Acumen, hospital systems may buy it like a package, get it, a starter of blood management through Acumen or some other systems. Ours here, Mercy Hospital here in Fort Smith, Arkansas, has engaged with the Acumen package, and they don't even fully understand that there's so much more, because they really have bought into how it affects the lab, starting from the lab, blood draws, but not the whole package of blood management and what that means in the OR, or even just up on the floor, managing patients' overall blood health.
Yes.
And so there's so much opportunity, even if they say, oh yeah, we're with Acumen or we're with AABB. There's so much education that goes into the administration even understanding, or the doctor's understanding, oh, it's the whole picture. It's the patient that leaves in a better state and not anemic, because so many of them are still leaving anemic, and the anemia was, even in the end of that, never treated. So the whole picture was kind of missed for the patient's health when they leave the hospital. Right. So we have so much education just in so many areas.
And I think that, I think that is so good, no matter how a hospital starts, if they invest in a package, then it shows that there's some interest in blood health. And I think, Sandy, you've ran into that. It's like, okay, now you've made this big investment, but we know that changing practice in an organization doesn't come in a package or a box, right? They do need boots on the ground, and they need the education, and they need, the personnel to be educated. They need people trained in it. And so I know that's where you're kind of struggling with, is you're trying to get your organization to see that, you've made this investment. So now let's, really, expand it to what it can be. So, and I do believe that, is there someone else? But I heard someone else talking. I'm sorry. I think James has a few more videos for us. So we're going to go ahead and move to James so that he can share some videos.
I met my husband in '92. He's from South America, Colombia. We were actually fixed up by a friend, And we got married in 93. And then after being married for 3 years, that's when I was first pregnant with Jesse. I had a great pregnancy. We were even able to travel. We went to Italy when I was 6 months pregnant. We had a great time. I felt great. I was able to work until my 31st week. I said to Jorge, something isn't right. I think my water broke. So we called my doctor and he said, stop what you're doing, get in the car and drive to the hospital. As soon as they went to examine me, a burst of water just came out. I was scared. I said, that can't be because I'm only 31 weeks pregnant. It's too early. And then they had one of the doctors come in to speak with me to go over the procedure, what was going to happen after Jesse was born because he was a preemie. I may not be able to hold him immediately. They'd have to whisk him away. And then the doctor said that they would check his oxygen levels periodically to make sure that he had enough oxygen in his blood. And then he said to me, but don't worry, we can replace whatever blood we take out. And at that point, I just jumped out of bed and I said, no. I said, did you read our paperwork? We wouldn't accept a blood transfusion. And he said to me, exactly, he said, oh, come on. This is your firstborn child we're talking about. I was frightened. I was scared. I didn't know how to answer him. So I just asked him to leave the room.
I felt that the hospital at the time was not fair with my wife. And my wife and I are one. And so, yes, they were discriminating against what I believed, what we believed, and what we wanted to achieve. We went to a hospital to begin with because we wanted the best kind of care.
I explained to Jorge what happened, and that's when he immediately called the hospital liaison committee, and they called Inglewood Hospital. I explained the whole situation to them, and they immediately sent an ambulance to pick me up. They brought me in through the emergency room, and as soon as I got there, Dr. Sasan was there to greet me, and the first thing he said is, you're in good hands, we're going to take care of everything.
Englewood was a completely different experience because in here, from the get-go, they had personal care. They understood what we wanted. They understood that we had rights, but they did so with so much care. They put my wife at ease the moment she walked in, and when Dr. Sasan greeted her, at that moment, you know that you are being properly cared for.
When he was delivered, he didn't even need oxygen. He came out breathing fine. He was actually pink when he came out. And I got to hold him right after as well. They didn't have to whisk him away because they saw that he was breathing when he was born. And so they let me hold him for a little bit, and I just felt relief. I think it was unique for myself and for Englewood Hospital because Jesse was the first premature baby born under the Bloodless program that needed to go into the NICU and needed special care, but at the same time was cared for by the best doctors that we have in the Bloodless program. So it was unique on both of our parts. I would want to tell them thank you so much for all the support. And it's not just getting us into the hospital and getting us that medical care, but the way they keep up with you. They come to visit. They call to see if you need anything. They make sure that all the doctors are working with you and that you're happy. The whole program as a whole is just a wonderful blessing.
When it comes down to decisions that are life or death, you want to make the right decision. And that's why my family has chosen to go to this hospital for not only the services that they provide, the quality of services, the quality of the staff, but because they respect what we believe.
Hi everyone, now I am going to show you the cesarean section. The indication of the cesarean section is previous cesarean section with fetal distress. I'm showing the easy technique of the cesarean section. Now I am going to make the incision on the skin, and you see the previous scar line. This is the phalansteal incision. Just I am giving the incision on the same line, and I am going to remove the scar also, so that patient will have not more than one scar.
लाइट पे उतना साफ नहीं है
I have removed the previous scar as a whole. Now I am going to open the peritoneal cavity by the cautery. Yes. I am cutting the rectus sheath now. This is the real unedited video. there is some adhesions of the previous cesarean. I am just cutting the adhesions between the two rectors. Now, okay, peritoneal cavity is now open. I'll just stretch. Okay. I am now going to retract the bladder, and you see the previous adhesions of the peritoneum. Now I will cut these adhesions. Bladder is adherent up to some extent, but I am separating by the sharp dissection. There is some bleeding. Now you see the scar, previous scar. So I will give the incision on the previous scar. Probably baby's meconium is strained. You see, this is the membrane, bag of membrane, and yellowish in color. Probably you have to make the incision at every level 10 centimeter. Yes, you see, this is meconium. I have already told you that you see. Okay. Yes, baby is crying. Baby is absolutely all right. Now I am handing over the baby. Now I am going to separate the placenta. 2 ampoules into synonym now has.
Well, I was really very pleased when I first heard that we were going to have bloodless medicine and surgery here. It's clearly increased the quality of our transfusion service in the hospital by making it more complete. When we go to a patient here, and if that person has, for religious reasons, for scientific reasons, for whatever reason, a preference not to receive blood, we now have a team of informed professionals who can deal with that. It's greatly improved the way that we can approach the community and say, come on in, we've got people who think the way you think. When I was trained, and that was back in the 50s and the 60s, we would transfuse at this level here. Someone came down to here, you had to be transfused. That number was probably, let's say, 10 grams per deciliter, 10. There's a person right in the hospital now. Her hemoglobin is below 6, and we're having a great difficulty matching her. Years ago, if she was at 6, that's a lot less than 10, we probably would have felt compelled to transfuse her with blood that wasn't perfectly matched. I saw her last night, I saw her early this morning, she's fine. And I've learned to be comfortable with that you don't have to transfuse here. You can go down here, you can go down here. In fact, you can just not transfuse. You have to balance the seriousness of complications of a blood transfusion with the transitory benefit of raising the hemoglobin over a few days. When a complication from blood does happen, it's potentially pretty serious, a life-threatening complication or maybe a lifelong infection. You can't get a complication from a blood transfusion if you didn't get one. That is a very key part of this new focus. I'm relying on my older colleagues to convey to my younger colleagues the reality of their experience of having given a unit of blood that caused, maybe it was HIV, maybe it was hepatitis C, and then questioning, did I really need to give Mrs. Smith that unit of blood that's caused her to have this complication? I've had open heart surgery, and I was faced with, do I want to get someone else's blood if I don't really, really need it? And when it really came to me, do I want to get someone else's blood? Only unless I'm as white as my white lab coat would I want to get a transfusion. Only if I was in a life-threatening situation. None of us want to give a unit of blood that's not necessary, because if it's not going to make things better, and it could make things worse, that's not good medicine. So it's the drive to do the best medicine that's possible with the least amount of blood that's possible.
I hope we all benefited from those videos. I really did appreciate, I think earlier in the week, how Inglewood Health said that once someone has made their declaration to decline blood products, they're never asked again. That is something that I think all hospital organizations kind of are challenged with. And also, I really enjoyed the MedStar physician who stated that you can't have a complication from a transfusion unless you first have one. So really, we want to make sure that we're giving the risk and benefit analysis to the patients to make a good decision. But now we will hand over the program to Nathaniel Usoro, who will be administering a quiz for us. Dr. Usoro?
Then, can I say something? There is a question there. I saw the question box. Though it's meant for the presenter of yesterday on Totema drug. I just saw a question there. If she is in attendance, can she answer the question? That my question is on the drug Totema. Is
she's
it
not in
available?
attendance.
Okay.
She's not in attendance, Abigail, and the question can be sent to our email, then we'll forward it to
Sarah.
her. And
Very good.
thank you very much. And thank you, Sarah, for bringing me back on.
Mhm.
I apologize for being the quiz master. That's like being an examiner, but this is not a real exam. It's just 10 brief questions to sort of remind us of some of the points we may have taken away from the webinars during this Bloodless Medicine and Surgery Week. So no need to have palpitations. I'm sure it will not be a big deal. So I'm going to launch the poll. The quiz is like a poll. So it should show up on your screens. And Sarah, you'll be reading the options. You don't need to delay to wait for people to answer because they'll probably be ahead of you. They have all the questions from 1 to 10. So
Okay.
without further ado, let me launch.
Okay.
Is it successfully launched?
Yes. And you want me to read the question and answers?
That's
Okay.
right.
Regarding blood transfusion, a single choice, does it improve tissue oxygenation, improve wound healing, helps stop bleeding, results in a faster recovery after surgery, or E, is associated with a higher morbidity and mortality?
So everyone in the audience can answer. Everybody can click on the answer and you can scroll down. You don't need to wait for Sarah. You can scroll by yourself. So far, I don't see anybody answering. Are we scared of answering?
I tried to answer and clicking on it did not do anything for it.
Because
Host
you
and
are,
panelists cannot
you
vote.
are,
Oh, because I'm a panelist.
Those panelists cannot. Can anybody in the audience try answering? Let's be sure this works. I don't see any answers. Okay. So can anyone in the audience, can you raise your hand or something to let us know whether you can see the quiz and whether you're able to click on the options? Okay. So Sarah, can you check? I think some people have raised their hands. You can pick anybody to tell us. You can, or the host, maybe the host can pick
I do not
anybody.
see the raised hands from my viewpoint.
All right, so the host can see the raised hands. You can pick, you can allow someone to speak so that we know what is going on because there's supposed to be answers.
Oh, I do.
Yes, I can click it.
Okay.
Yeah.
Okay,
right.
I have seen an answer coming in. So others should please be answering. It looks like only one person in the audience is trying to answer. If one person can see it, then others can see it. Okay, Sarah, go on reading.
So question 2, regarding iron therapy and anemia. Single choice, 70% of anemic patients present with absolute or functional iron deficiency. This is an important technique in the second pillar of bloodless medicine and surgery. Intravenous iron is first choice regarding the route of therapy. Oral iron is best used with erythropoiesis stimulating agents. Or E, blood transfusion is safer and more effective than IV iron therapy.
Yes, go ahead.
Question 3, regarding erythropoietin. A, is it best used with oral iron? B, is it associated with hazards of hemorrhage? C, it is a steroid hormone. D, it can increase blood count by increasing bone marrow activity up to 4 times. E, it lowers platelet count. Regarding advanced medical directives, A, nurses have no role. B, relatives can override patient's documented choice if they are unconscious. C, advanced medical directives do not need to be documented in Jehovah's Witnesses. D, respect for patient autonomy is number one principle of medical ethics. Or E, do not include end-of-life issues.
Okay, 1 second, Sarah, please. Let me inform the audience that you don't have to be a medical student or nursing student or a student to go on and try the quiz, the poll. Everybody in the audience can try it. Go ahead, Sarah.
The fifth question, blood salvage. A, is expensive and not practical in most cases. B, cannot be used in obstetrics. C, can greatly reduce blood loss even in high hemorrhage surgery. D, makes it difficult to estimate blood loss. Or E, cannot be used in orthopedic surgeries. Question 6, bloodless medicine and surgery. A, makes for more ethical challenges in medicine than in blood transfusion. B, gives importance to patients' own blood. C, gives the opportunity to surgical teams to improve their skills. D, requires much technology to practice. Or E, is not practical in all cases. Question 7, regarding tranexamic acid. A, is a procoagulant. B, can only be given intravenously. C, cost is the limitation. D, greatly limits hemorrhage in trauma surgery, obstetrics, dentistry, and hemophilia. Or E, cannot be used in elderly patients. Question number 8, regarding sickle cell disease. A, blood transfusion is still the best scientific option. B, hydroxyureas reduce pain, hospitalization, and increase hemoglobin and lifespan. C, L-gluten has been found not to be useful. D, alloimmunization is a safe, effective alternative to transfusion. E,
It's a side effect.
is a side effect. Alloimmunization is a side effect of alternatives to transfusion. E, blood transfusion reduces viscosity and improves tissue oxygenation. Question number 9, regarding topical hemostasis. A, all require biological tissue. B, they are used only in the skin, on the skin. C, flat surfaces are required for use. D, they can greatly limit blood loss in liver and cardiac surgery. Or E, they are not to be used with other blood conservation techniques. And our final question regarding bloodless surgery. A, Dr. Denton Cooley was the first to carry out bloodless surgery. B, World Bloodless Surgery Day is to celebrate Dr. Cooley's birthday. C, by 1977, Ott and Cooley published over 500 bloodless cardiac surgery cases, with similar or better outcomes as transfused patients. D, bloodless open cardiac surgery is possible, but not bloodless cardiac transplant. And E, it is only Jehovah's Witnesses that should be offered bloodless surgery. And that concludes the quiz.
Thank you very much, Sarah. Thanks for your excellent reading. I had to bring you in because if I read it, many people in the audience wouldn't understand with my Nigerian accent. So we'll give a little more time to, I think a lot of people are now into the quiz. And I think we do have time since it's only 10 questions.
Yes.
So
the quiz provided a great review of the presentations that we've reviewed over this week.
And that's a big thank you to the various speakers who were able to really cover their topic so well. And Abigail, Abigail and Sarah, please, could you still take a look again at those Q&A questions? Just in case there's anyone that is relevant for today. Somebody said, I'm not seeing the questions. But lots of people
And
are answering.
someone is saying that it won't submit after they've answered one. It wouldn't submit for the rest.
Okay, yes, it forces you to take everything so that we can.
And Charles Egbor says, I am not seeing the question. Can you see, Nathaniel, how many people have completed the quiz?
I'm sorry, my connection became unsteady. So I was asking Sarah, do you think it's a good thing or a bad thing what Zoom is doing, forcing people to answer all questions?
I think it's a good thing. At least it lets us know where we're at, right?
Yeah, lots of exams will say you must attempt all questions. And even if you don't know, you should guess. But I've never figured out whether that is just for research purposes or it actually helps to evaluate the candidates' knowledge.
Can you see how many people have completed the test?
Yeah, let me see. Let me see what that it looks like. It looks like all those who wish to complete. There's still some more.
Okay, we want to make sure that everybody is calculated in, so we'll give it a few minutes.
Yes. So it doesn't have to be every single person must participate before we end the poll. We can end it in a couple of minutes, but we just want to make sure that those who are interested in participating are not locked out, because I still see the numbers increasing.
Michael Rohr said, thank you for the C-section video. They were surprised by how quickly they clamped the cord. And I see C-sections regularly in my institution, and you are right, Michael. Usually, unless there's a problem with the child, if they're having some complication, if we've got a healthy delivery, we wait a good solid minute for that cord usually to be clamped. It gives that baby back all of as much blood as possible. So good catch on the video.
And some would advocate holding the baby a bit lower than the table before clamping the cord, so that by gravity, much of the blood will go to the baby.
Oh, wow. Say, I haven't seen that, but that's interesting too. It was a very good representation of a C-section. That's very typical of what I see, on a daily basis.
And it looks like it's from Dr. Nesagika's country, that is India.
Okay.
Prabhu is practicing in Bangalore. He was one that was talking on topical hemostats.
Very nice.
Okay, so I think I should. Oh wow, so many people suddenly. So in 1 minute, I am going to end the poll. So whoever is struggling should try and catch up.
It's good to see everyone trying to participate. It takes a moment to figure out the technology, you know.
Yes, okay, that's a point. It does take a while. So we have 45 seconds to the end. And then it's 30 seconds to the end. I think I am chief examiner for the paper question next week in surgery in my department, so I can practice now. 10 seconds to go. And here we've come to the end of the exam. So we're going to end the poll and publish the results. Don't be afraid, nobody's name will show. Is it showing there?
Yes. Yep.
Oh, good. Okay. So let's take the questions one by one. And the good thing is that we have some people with various different opinions. So let's see which one is correct scientifically. Number one, regarding blood transfusion, A, it improves tissue oxygenation. That is what we all thought, and many still think so, but not a single shred of scientific evidence of that. Rather, all the research commissioned, even by the National Institutes of Health, have come back to say that blood transfusion reduces tissue oxygenation. The recent one is in 2021, the recent paper to that effect by Majed Refai and colleagues from University of Rochester. Improves wound healing. All papers on blood transfusion are united that it delays wound healing. Helps to stop bleeding. Again, blood transfusion prolongs hemorrhage. Please check up on upper GI hemorrhage, which is one area where often we prescribe blood transfusion. So what does the research show as to what it does to that hemorrhage? Prolongs it, and actually also causes repeat hemorrhage, which is a problem in upper GI hemorrhage. Results in faster recovery after surgery. That's what we thought again, but every single study done shows that it delays recovery. Is associated with higher morbidity and mortality. Again, this is no question. Nobody's arguing this anymore in 2023. There is higher morbidity and mortality from blood transfusion. So the answer there is E. Am I correct, Sarah?
Yes, you are.
Okay, thank you. Then number two, regarding iron therapy and anemia. 70% of anemic patients present with absolute or functional iron deficiency. That's what we learned from the talk given by Professor Manuel Munoz. They've done research on it. They found that most patients with anemia would have iron deficiency anemia. Therefore, if you don't have any facilities for checking so many things in a patient with anemia, you may not go wrong 7 out of 10 times if you give iron and B12, folate if there's no malignancy, and vitamin C. Iron therapy is an important technique in the second pillar of bloodless medicine and surgery. Well, it's actually the first pillar, optimizing the hematocrit. So yes, it's under a pillar, but the first pillar. Intravenous iron is first choice regarding routes of therapy. Intravenous iron is very effective and may have to be used as the only option in certain situations. For instance, if the patient is not taking orally or perioperatively or certain situations, inflammation and so on. But oral routes remains the first choice if you have enough time and the patient is able to take by mouth. So in medicine, we try to avoid more invasive options when we have less invasive options. So we don't discount oral iron at all. Like pregnant women, they should be on prophylactic oral iron and even therapeutic until about the second, third trimester. That's when because the time is near. So when the time is short, also we go for intravenous. Oral iron is best used with erythropoiesis stimulating agents. No. As a matter of fact, if we were giving erythropoietin or any erythropoietin stimulating agent, we should use intravenous iron with it. Blood transfusion is safer and more effective than IV iron therapy? Certainly not. There's consensus now. There are consensus statements on use of IV iron as a safer and more rational approach. The World Health Organization encourages us to use it as safer among the descriptions that they give. Regarding that, and so the answer there is what? A, right? For number 2 is A. For number 3, regarding erythropoietin, what happens when I scroll? Does it scroll over there or you're free to do your scrolling?
I think I'm free to do my scrolling. I'm not sure how it happens for everyone else.
I think in the interest of justice, it should be the same for all. So regarding erythropoietin, it is best used with oral iron. Please, Sarah, if I give the wrong answer to any, kindly correct me. So it is best used with oral iron. I think we already agreed that erythropoietin should always be accompanied with IV iron. We don't even give erythropoietin alone, but if we have to give it with iron, but not oral. It is associated with hazard of hemorrhage. No. In fact, those who are concerned with erythropoietin would be worried about thrombosis, which is not very often. It is a steroid hormone. Thankfully, nobody said it is, even though it's a banned drug in sports, but it's a glycoprotein. It can increase blood count by increasing bone marrow activity up to 4 times. Yes, that it does. And that can rapidly boost the blood level. It lowers platelet count. No, it actually increases platelet count. So if you don't have the specific agent, thrombopoietin, for increasing platelet count, you can use erythropoietin. You can also increase the white cell count because it works right at the stem cell level sometimes, yeah, to increase the bone marrow activity. Number 4, so the answer to number 3 is D. And for number 4, regarding advanced medical directives, nurses have no role. I'm sure there's no nurse here that answered yes to that nobody else did. And B, relatives can override the patient's documented choice if they are unconscious. Well, the answer is no. They cannot validly override, except I think if the medical people are not really medical people. All truly medical people recognize that patients' wishes, when documented, should not be overridden. And of course, the possibility of being unconscious is the reason why the advanced medical directive is made, so that if the patient is unconscious, the document will speak for him or her. Advanced medical directives do not need to be documented in Jehovah's Witnesses. In the eyes of the law, they have to be documented in everyone. Yeah, respect for patient autonomy is #1 principle of medical ethics. Many people do not know this, but yes, it is the #1 principle that you cannot put anything in a patient's body or do any kind of medical intervention for a patient without their consent. So they do not include end-of-life issues. As a matter of fact, advanced medical directives do include sometimes end-of-life issues. So the correct answer here is D for number 4. Number 5, we're like halfway through now. Blood salvage is expensive and not practical in most cases. Not true. First of all, there are cheaper forms of blood salvage, like even the scoop and sieve method, which is just scooping blood maybe from the abdomen. Let's say it was ectopic pregnancy or splenic rupture, scooping and then pouring it into a gauze, which is spread over a jug. So the gauze sieves the blood into the jug and then it's funneled into a blood bag and then given to the patient. It's possible. That's a very elementary form of blood salvage. And then we saw the Dr. Waters showed some cheaper options that have been made, which are quite practical, have been developed. And even one of the presenters of the industry presentation showed us a very inexpensive and simple to use method, which is not necessarily just for developing countries, but they're promoting it all over the world. And but if you're doing like high-tech surgery, if you're doing open heart surgery, liver resection, and so on, you can also add a little more, a cell saver. That wouldn't cost that much in that setting. Cannot be used in obstetrics. We heard Dr. Waters clearly let us know that it can, and it is used even for to recover vaginally shed blood. Can greatly reduce blood loss even in high hemorrhage surgery. Again, we heard Dr. Waters tell us about someone that had lost like 2 times the blood volume, and yet there was no effect because everything that was lost was sent back to the patient. Makes it difficult to estimate blood loss? No. In fact, sometimes it's easier to estimate because you can see the gradation of whatever is collected. Cannot be used in orthopedic surgeries. Orthopedic surgery is one of the areas where cell salvage is recommended. So the answer here is C. Sarah, am I correct?
Yes, you are correct.
Okay. It's supposed to be simple, single choice. So if you notice that there's more than one, please let me know. 6, bloodless medicine and surgery, A, makes for more ethical challenges in medicine than in blood transfusion. So when we talk of medical ethics, the number 1 is autonomy, patient autonomy, as we mentioned. The second one is non-maleficence, don't do any harm. The third one is beneficence. You should benefit, whatever you're doing should benefit the patient. And the fourth one is justice, should be fair to all patients. And recently, there's been an attempt to add other things like compassion, which is going to be the theme of the Bloodless Medicine and Surgery annual meeting coming up in November, and a few other things. But the core aspects of medical ethics are the 4 that I mentioned. So how do bloodless medicine and blood transfusion, how do they compare? Autonomy. Would you say that blood transfusion offers better options for autonomy? Certainly not. I think we agree that bloodless medicine is the way to go to actually respect patients' wishes. Non-maleficence. Blood transfusion does no harm, it does a lot of harm. Bloodless medicine, nobody is able to put a finger on the harm it does. Nobody. There's always a question, are there no side effects? Are there no hazards? We don't really know any. Yeah, some of the medication, you need to use them within the dose range and avoid them in certain situations. But when used appropriately, you cannot say you're harming the patient. But for blood transfusion, you can say you are harming this patient. You're causing immunomodulation in all patients. You're causing hypoxia, and we're not even talking about transfusion transmissible infections and so on. Beneficence, again, the efficacy is not just the hazard. The efficacy of blood transfusion has been challenged. What does it do? Does it optimize tissue oxygenation? It doesn't. Does it reduce bleeding? It doesn't. It doesn't really do, and we cannot put a finger on what it does to benefit the patient. So you can say, oh, somebody was had lost a lot of blood and was dying of, and then was given blood transfusion and was resuscitated. Yes, that is because blood transfusion is a colloid. So if somebody lost a lot of blood and you are continually pouring in saline, then at a point, that patient will be overloaded, number one. Number two, the tonicity will not hold up. So that patient will eventually die, either of overload or shock. So it doesn't mean that it's blood transfusion that saves the life. It's a colloid, and blood transfusion is a dangerous colloid to use. We have colloids off the shelf we can use. Another possible way somebody could say, oh, blood transfusion has saved lives, it has iron. Every unit of blood has 200 milligrams of iron. The body would recognize the rest as foreign material and throw it out, but it may make use of the iron. And we know that iron is a potent agent for erythropoiesis. Even when there's no even when erythropoietin is not added from the outside, if there's iron, the body will use it. But if you must give blood transfusion in order to give iron, that is a very crude biological therapy. You can administer iron from a bottle of IV iron, much cheaper and safer. So I would say, I would agree with this option that sorry, I would disagree to say that bloodless medicine makes for more ethical challenges. It actually removes, that's why the WHO is encouraging us to move away from blood transfusion to patient blood management, as they call it. Gives little importance to patient's own blood. Dr. Krishnamurthy let us know that bloodless medicine actually revisits the patient's own blood as being the main thing to concentrate on, building it up and preserving it, minimizing the loss. Gives opportunity to surgical teams to improve their skills. Again, Dr. Krishnamurthy explained why this is so. Requires much technology to practice. We heard from one of the participants in the panel yesterday who doesn't have a cell saver, sometimes doesn't even use diathermy, but is doing bloodless cesarean sections, bloodless myomectomies, and so on. So what we need is education and to master the principles, know the techniques. We can practice whatever we are doing now with the available technology we have. We can do it better without blood transfusion. It's not practical in all cases. Again, the challenge here is which case are we talking about that it cannot be used? We don't know any, and nobody is able to come up. There's not a single speaker in any conference, even in a blood transfusion conference, they cannot come up with a case that cannot be done bloodless. Of course, it's easy to understand why. To start with, the blood transfusion never added any value to that case or surgery. It didn't improve tissue oxygenation, it didn't reduce hemorrhage, it didn't do anything. So if you do without, and then you add the techniques of blood conservation, then virtually all cases. I mean, if you can do it in open heart surgery, why can't you do it in other cases? Transplantation is being done. Those are high volume loss surgeries. Tranexamic acid. Oh, so the answer to number, what number was it? 6. Number 6 is C, please. Answer is C. And to number 7, tranexamic acid is a procoagulant. It may appear that way, but it's not. So, so when people say, oh, tranexamic acid will increase the rate of thrombosis, it doesn't, because it's not a procoagulant. It is an antifibrinolytic. That's what it is. Can only be given intravenously? No. We were told during the week that it can be given orally, can be given by inhalation, and I think topically as well. Cost is the limitation. Again, the presenter broke down the cost, or she didn't give it in dollars. But I think she didn't give it in dollars because it worked out into cents. because even in my environment, it's extremely cheap. I think she said a bottle is 500 naira. So that may be a little over 50 cents or so, at least in my environment. Greatly limits hemorrhage in trauma. Sorry, did I say over 50 cents? It will be less than 50 cents. Greatly limits hemorrhage in trauma, surgery, obstetrics, dentistry, and hemophilia. That is true. Because surprisingly, one may say, oh, it wouldn't have a benefit in hemophilia. It does. Cannot be used in elderly patients. That's not correct. It can. So the answer here is D. And we are moving on to number 8. Regarding sickle cell disease, blood transfusion is still the best scientific option. I'm glad nobody said yes to that. It is not. It is an unscientific option, even for patients who are not declining blood transfusion. Hydroxyurea reduces pain, hospitalization, and increases hemoglobin and lifespan. This is a surprise to me, but it's true. It was there in Dr. Su's lecture. Why it's not a surprise to me that it reduces pain and hospitalization, but that it increases hemoglobin and lifespan. So that is correct. L-glutamine has been found not to be useful. No, it's very useful. Dr. Su explained how it reduces oxidative stress and some other mechanisms that greatly helps in sickle cell disease. Alloimmunization is a side effect of alternatives to transfusion. Not at all. Not at all. It is a side effect of transfusion in sickle cell disease. And again, Dr. Su told us about somebody who had been so transfused in the US that they couldn't find any group anymore, any blood group anymore to transfuse the patient with. Otherwise, the patient will be killed by the blood transfusion. I think they said they finally found a unit in Scotland for somebody in the US. And of course, by the time the patient receives that unit from Scotland, probably there will be no other unit left that he or she can accept. So as patients keep receiving blood transfusion, the body knows that it's a foreign material. And so it builds up immunity, not only against the ABO and RH, which is all we check for. There are many other antigens in the blood, and the body will get ready to fight every single one of them if they come back. Blood transfusion reduces viscosity and improves tissue oxygenation. Again, on the surface, this is what we may think, but even in textbooks of medicine now, they are documented that it increases viscosity and reduces tissue oxygenation. These are opposite to what you want in sickle cell disease. Remember, things that cause sickling, viscosity of blood is one of them, hypoxia. So that's why somebody asked a question on the day Dr. Su spoke, that what are those cases where we must use blood transfusion for sickle cell disease? And that question was not answered. It was afterwards, it was later answered by typing that it is difficult to imagine actually the situation where blood transfusion will be the answer in sickle cell disease, because it does everything that sickle cell disease patients cannot tolerate. We've talked of increasing viscosity, causing hypoxia, but in my setting, for instance, we don't have blood warmers. So likely it's going to be cold from the blood bank, and then we just warm it a little in the environment. So if you keep giving lots of units, then the patient goes into hypothermia, and that is a cause of sickling. It's going to cause acidosis. Acidosis causes sickling. It's one of the side effects of blood transfusion. It's documented in all textbooks. So virtually all those problems of blood transfusion are things that increase problems in sickle cell disease. So the answer to number 8 is B. Hydroxyureas reduce pain, hospitalization, and increase hemoglobin and lifespan. Penultimate question regarding topical hemostats. All require biological tissue. No, there are some synthetic ones. Yes, platelet gel and platelet-rich plasma are autologous. They are from the patient's own tissue and then biological. And there are other ones. There are other ones that are biological, but some of them are synthetic. They are used only on the skin. Well, that may sound like that, the word topical, but no, they can be used within for those that are designed for use within the body. Flat surfaces are a requirement for use. No, they have the ones like gel foam, others that conform to the surface where it's applied. They can greatly limit blood loss in liver and cardiac surgery, certainly, and many other types of surgery too. Like if there's a resection of the liver, you might not be able to catch a blood vessel on the liver, on the raw liver surface. It's just oozing. And so using a topical hemostat can greatly minimize or stop the blood loss. They are not to be used with other blood conservation techniques. They should. In fact, when in all those techniques in the 4 pillars of bloodless surgery, first pillar, optimizing tissue oxygenation, second pillar, minimizing blood loss, third pillar, optimizing tissue oxygenation. The first one was optimizing the hematocrit. Now, the third one, optimizing tissue oxygenation. The fourth one, supporting patients' tolerance of anemia. So all of the techniques under these pillars should be used where possible. It doesn't mean that we always use all. We have to tailor it to the patient. Some patients may object to some, and some may be inappropriate for some patients. But we don't use one single technique. Say, okay, topical hemostat, that's okay. That's all we need. No, use as many as possible. So the answer to the penultimate question, number 9, is D. And the final question regarding bloodless surgery. Dr. Denton Cooley was the first to carry out bloodless surgery. Well, as a matter of fact, no. Prior to 1900, bloodless surgery was standard because there was nothing like blood transfusion anyway. However, we do define bloodless surgery now as a very deliberate attempt with using protocols to avoid donor blood and with the aim of improving outcome. So we could say before 1900, they didn't have a choice. But today we have a choice and we are choosing bloodless surgery. Dr. Denton Cooley was the first to carry it out in open heart surgery, which was thought to be a no-go area for bloodless medicine because of the expected high volume blood loss. But he figured out how to do it and to do it with better outcomes. World Bloodless Surgery Day is to celebrate Dr. Cooley's birthday. And no, I'm not sure we even know when he was born. It is to celebrate the day that Dr. Denton Cooley carried out his very first open heart surgery without transfusion, bloodless open heart surgery on one of Jehovah's Witnesses. That was May 16, 1962, 61 years ago. Okay, so by 1977, Ott and Cooley published over 500 bloodless cardiac surgery cases with similar or better outcomes as transfused patients. Yes, it's still in the scientific literature. And he went on to do some more than 1,000 more. And he was Cooley was the chairman of the Texas Heart Foundation, I believe, until his demise a few years ago. Bloodless open cardiac surgery is possible, but not bloodless cardiac transplant. It may seem that way, but no, it is possible to do bloodless cardiac transplant. In fact, the cardiac surgeon who gave the World Bloodless Surgery Day lecture on Tuesday, that's his specialty, doing bloodless cardiac transplant. And recently, many centers have adopted it. This very month of bloodless surgery, there's a center that just recently announced their first bloodless cardiac transplant. Sarah, did you take note of which center that was?
Of the recent one, I think it was.
Oh, this month.
Was it Boston or?
I think so, Massachusetts Hospital. Yes, that's correct. So it's very possible to do bloodless cardiac transplant. Again, that raises the question, if you can do that, what case then can you not apply bloodless techniques? It's difficult to fathom. And nobody has been able to say what case you cannot do bloodless with. It's only Jehovah's Witnesses that should be offered bloodless surgery. Remember the ethical principles of autonomy, non-maleficence, beneficence. The fourth one is justice. Therefore, it is not right to offer only one set of people an option that is better. You should offer all patients. And of course, it's not only Jehovah's Witnesses that request bloodless surgery. Many patients, as we pointed out in my own center, they'll come in and they say they don't want blood transfusion. And the surgeon will ask, are you a Jehovah's Witness? Patient says no. The doctor says, okay, you must have 4 units of blood. You're not a Jehovah's Witness. Why are you saying you don't want blood transfusion? And I have been called for some patients. And in the consult, it says, please see this Jehovah's Witness patient and help with the perioperative management because he or she has declined blood transfusion. And when I actually go to see the patient and I venture to, maybe I take a look at the folder where the patient's biodata have been documented, it clearly says some other religion. And the patient says, well, I'm not a Jehovah's Witness, but I don't want a blood transfusion. And just like Dr. Steve Frank said, we don't tell them, oh, you should take blood. No, we say you're smart for declining blood transfusion, and we are caring for everyone. And we care for them, and the outcome is similar. I agree that faith is an important component of healing, but at least they've shown some faith by saying they don't want a blood transfusion, so they still come out well. Okay, so that's the last question. And how well did you do? You score yourself, because here there's nobody's name is here. It's just general. And I think, generally speaking, many people here scored correctly. There are some questions that were a bit tricky. So even a clinician needs to read it twice to be sure, because there's a catch somewhere that may account for some of the wrong answers. So let me go off at this point and hand over to Sarah. Thank you very much.
Thank you, Dr. Usoro, for your passionate continuance of patient blood management, bloodless medicine and surgery. And this program, this kind of draws a conclusion to our week of activity. And we feel so honored to be together globally as a group to discuss this. If you have any questions or over the quiz, or you want to discuss it more, I know that Dr. Nathaniel Usoro would love to hear from you. So please reach out to him. Thank you so much to the Bloodless Medicine and Surgery group in Calabar, Nigeria, for all of your hard work in organizing this. Also, the Society for the Advancement of Patient Blood Management. Greatly appreciate the work that's being done. And heartfelt thanks to Abigail Ivara, my co-host today. I'm going to turn it back over to you for your concluding thoughts.
I appreciate you, Sarah. Thank you very much. You've done a very good job. Thank you, everybody, both the participants, the panelists, moderators, the organizers. We are very happy to have you. If it's possible, we would have continued, but we just have to have a break so that we'll go prepare for November program. I'm very grateful to have you. Please do join us again some other time. I appreciate it.
Dr. Usoro, do you have any concluding thoughts?
Did I mute myself? Okay, that's clear. So thank you very much, Sarah, Abigail, and everybody. Before I say anything, let me allow someone here whose hand has been up. Dr. Agu, his hand has been up. He wants to say something.
Yes.
Dr. Agu, go ahead, please.
Good afternoon, good evening. Dr. Soro, thank you very much. I have always followed this program right from the inception, when it was still in the formative stage up to this moment. You know me very well. We're good friends, and now I'm not practicing in Nigeria now. But when I was in Nigeria, that was I left Nigeria in 2020. What we call Japa. So I'm in Saudi Arabia. And I was involved in this bloodless medicine for Jehovah's Witnesses in my hospital. And we were doing the little we could to treat witnesses. That hospital is still my private hospital, although I was working with a teaching hospital. In that private clinic, we're doing quite a lot for witnesses using what we could afford within the environment where we were. So it's really been interesting listening to these programs yearly. And I think I gained quite a lot. Like this time around, I was so lucky that I was free all the time that the program took place from, I think from Tuesday up to, I followed everything from the beginning to the end. So I was so lucky that I was not on call within this period. So I was free to follow everything from beginning to the end. And in your last quiz, Paul, that you gave, I'm supposed to score 100 over 100. I haven't followed everything, but you made me to score 9 over 10. And I want to know why, because number 2 question, you said is A, whereas I chose C. The option that people gave there was C. The option that was given in the written, that's the option that you showed us on the screen was C, which I chose, but you said it's A. So maybe you can just clarify that before you give your final thoughts. Thank you very much for all the information. They were quite useful. They were really very, very, very educating. So, and I appreciate everything. It was really nice following you. Thank you.
Thank you so much for that, Dr. Admin. I think you're a great ambassador of bloodless medicine and surgery. Wherever you jump to, it's fine. We want to spread the message. And I'm glad you were not on call this week. I pray that you wouldn't be on call in November again, because we have our annual meeting coming up November 1st to 3rd. Sarah, have I got the date correct? I think so.
I believe so, yes.
So, yeah. So let me go to that question too, because if we were wrong, then we need to be corrected. Regarding iron therapy and anemia, 70% of anemic patients present with absolute or functional iron deficiency. So that is there on Dr. Sue, sorry, not Dr. Sue, it was Dr. Munoz. Let me see whether I can. Are you able to see the slide I'm sharing?
Yeah, I'm seeing.
Okay, let me see if I can move it to where he actually showed it. I'm minimizing the. Oh, there you go. So did I get it right? 70% of anemic patients presented with absolute or functional iron deficiency. So most times, if you give IV iron, you're on the right track. Even if you were not able to assay, and even sometimes if it looks like the iron is okay, there can be functional iron deficiency. May not be absolute, may be functional. And that is why when we give erythropoietin, we have to give IV iron, because the iron stores may look okay, but there's a functional deficiency. Now, so that we've established is correct. Now, let me stop the share and see if I can retrieve that poll that disappeared. I minimized it, but lo and behold, it seemed to, okay, it's back. Managed to bring it back. So,
and do we know which one he chose? What was the answer that he chose?
I chose C.
He said he chose C. Now, C says intravenous iron is first choice regarding the route of therapy. So as much as we appreciate and admire the benefits of intravenous iron, we still go for oral as first choice. For instance, I think Dr. Agu, you're an obstetrician, right?
No, I'm a plastic surgeon.
Oh, I'm sorry.
Yeah.
I'm mixing you up with another surgeon. So, but if we go to the obstetricians, for instance, they could have a patient with anemia in the first trimester, hemoglobin 9. They may not go for intravenous iron because they have time. So they'll give the patient oral iron. They might increase the dose, add folic acid, vitamin C, and so on. And that may be the solution. By the time the patient is in the third trimester, hemoglobin could be 12 or above. But if a patient is presenting in the third trimester, suddenly or late second, they'll go for intravenous iron. So intravenous iron is not always the first choice.
Can you look at the question again? That question number 2. Can you look at
regarding iron therapy and anemia, intravenous iron is the first choice regarding route of therapy. Oral is the first choice. Talking about the route.
But in your choice there, you wrote C.
No, I said A is the correct one.
No, I mean in you know, you were given the answers as a footnote after each question. It was C that was there. If you can look at it.
As a footnote, no, I wasn't that. I'm not that smart with Zoom.
Okay.
So look at. I think you can scroll and you see that there was no footnote.
No, you were given answers. You were given all the answers. Yes, the answer you gave there was C. So.
Oh, I'm sorry if I did that.
Oh,
Yeah.
The answer is A.
Okay.
The answer is A.
Okay. So 9 over 10 is not bad.
Not at all. I'm not sure I could have scored that much if I didn't have access to the answers. Thank you very much, Dr. Agu. And thank you very much to everyone who has been here. I'm sure you will agree with Dr. Agu that it's been a really informative and exciting week. And I would have said, let us check again. Maybe somebody has shown up from Antarctica, but I haven't had the time to create that kind of poll again. But the point is there's a worldwide audience here, and that has made the program to be richer. Like Dr. Agu is calling in from Saudi Arabia. There are people from Europe, from Asia, and all continents, so to speak. So we want to keep the flag flying, keep the fire burning wherever we are, because this has to do primarily with saving lives. That's what it has to do with. Everything that we are doing in respect of organizing this event is to save lives. And if we can save even one life because somebody had listened to this and was able to apply this to a patient, whether it's a patient who declines blood or a patient who doesn't, that would be wonderful. Yesterday, we heard one of the panelists on the panel who said he was a doubting Thomas, and he's correct. Now I remember, I forgot, I would have told him that yesterday, that I remember the emails he used to send to me and calls. He used to call me. Now I remember very well. He used to call me when he faced certain specific situations. Is this possible? How do we go about this? And he never missed any of them. So definitely the webinars have been useful because especially since we went online. So more people from more places have been able to join and apply what has been learned. So I think I'll leave the final thanking to the moderators for today. But I want to remind us also that we have the annual meeting of the Bloodless Medicine and Surgery Society coming up. I think we mentioned it already, November 1 to 3. Let me see if I can persuade Zoom to allow me to show the flyer, the poster for it. Just so that we keep this in mind, that hopefully we should meet again in a few months, in about 6 months, I think. Yep. Right. So now I'm going to share my screen. Let me stop the sharing of the poll. Okay, there we go. Can everybody see it? Okay, so please save the date. It's November 1st to 3rd, the annual meeting, and the theme is compassion at the heart of bloodless medicine. I can't wait for this because I want to hear how compassion is at the heart of bloodless medicine. So thank you everybody for being here, and hopefully we'll see you again in a few months. Over to you, Sarah and Abby. Sarah, you're muted.
Thank you, everyone, for taking the time to be with us. And we look forward to being with you again in November 1st. And until then, stay connected to Blood Health, stay connected to an organization and people who are promoting blood health. And we just encourage you to, if you need assistance or help in any way, reach out to these societies so that we can get you the help that you need. Abigail?
Yes, yeah. Thank you so very much, Sarah. The audience and everybody, let your blood remain in you. Advocate bloodless, and please remain healthy. Thank you very much for coming. Bye-bye, everyone.
Bye-bye.
Bye-bye.
Bye.
And Ananthi, others, you're free to say bye-bye, please.
Bye, everyone. Thank you.
Bye. We love you all.